We have some wonderful speakers today, but before we start, I'd like to update you on a project that is currently underway in the region. By the way, my name is Sian Summers and I'm one of the Senior Quality Improvement Managers in the regional team. Thanks. Next slide, please. Okay, so a project that's underway at the moment within the region is the Black women's experiences of perinatal mental health. As we know, women have access to both maternal mental health services and perinatal mental health services across the region, but from recent MBUs reports and many of the other national reports that have come out, perinatal mental health still remains one of the main reasons for deaths in women, particularly in the postnatal period. This is recognised as one of the elements of the new maternal care bundle on perinatal mental health. And I understand that Liz is going to mention this later in her presentation. Black women specifically and women from other ethnic minorities have also been shown to be more affected by perinatal mental health issues and are less likely to access services. So, for example, 13% more Black mothers experience postpartum depression than any other group. And in part, this can be because Black women are currently 2 times more likely to die during pregnancy or shortly after childbirth compared to white women, as Embrace let us know last year. And awareness of the statistic among Black women and birthing people is high, which can often increase stress, fear and anxiety in the perinatal period. So we've got part of the drive is to understand and improve services for all women, and those women particularly in this project, and to gain an insight into what women feel about their experiences in perinatal mental health, and then to put in place improvements focusing on the needs of ethnic minority groups and culturally sensitive practice. So what we've done is we've co-created a feedback form in the project group, including representations for all the Southeast Perinatal Mental Health Trusts and women with lived experience. It's currently in the process of being translated into 10 of the most common languages in England. And then we're going to trial it across the trusts over a 2-month period to see if we can gain some useful feedback for improvement and changes. We're hoping to report back at a future webinar on our findings. And if any of you would like to be involved, my contact details are on the bottom there, and I'd love to hear from you. So now we're moving on to our first presentation, which is Paddington Virtual Reality. This has me very excited. Immersive sensory technology to improve experience and outcomes of pregnant women and birthing people affected by procedural anxieties and nosocomophobia. And I had to look that up, and it's fear of hospitals, I understand.
Yeah, sorry, it's because so we love long titles, don't we? So make sure that we use them the correct term. So as you were just saying, Sian, you're correct. It's the extreme fear of clinical environments or hospitals. So my name is Heidi Otterson. I'm a consultant midwife, and my colleague Sam Fleming is also on here. We are doing a joint project, pilot project here at the Royal Berkshire Hospital. It's still early days, so we just wanted to share with you how far we are at the moment. And Sam has just entered the screen there. Next slide, please. Thank you. So as consultant midwives, we often see women with different complexities in our clinics. One of our referral criteria for our clinic will be women with needle phobia, for example, or any sort of procedural phobias that may affect labor and birth, but also well-being in the postnatal periods. So Sam and I have been curious about trying to look for some solutions around how we can best support these women to overcome some of those barriers. And it's really quite important that we address this area, as we do know that women who suffers with procedural anxieties or phobias are far more likely to have poorer birth outcomes, but also not just for the pregnancy and birth, but long-term health outcomes for themselves and for the families, as often we also find that they're unable to accept screening offers for their children when they become bigger. So it affects the whole family. These women are more likely to experience care hesitancy. So we find that some choose to birth outside the national or local guidance as they do not wish to come into a hospital setting. they're more likely to decline screening during the pregnancy, but also generally book their pregnancies quite late. During the labour and birth, we find that any injectables, perineal repairs are being declined because of the fear of needles, and they often experience the birth complications significantly more than a woman who's able to accept routine care during labour and birth. More concerningly, I mean, in terms of in this project, is that what we do see as well is sort of choices around labour and birth in terms of access to proper analgesia and pain relief. These women are more likely to require sedation as part of their labour and birth care or a general anaesthetic, which does mean it affects the mum and baby unit, the dyad between the parents, as the baby is more likely to be separated from its mother after giving birth. As you can probably imagine, I don't know how many of you on this call are clinicians as per se, but we do find when you see people with needle phobia, the most common sentence you hear is you just need to take a deep breath in. You just need to look away. Oh, don't worry, it's just a small scratch. But actually for the women, this is a significant barrier to overcome, which affects their life throughout the whole lifespan and can also lead to significant postnatal depression and PTSD, as often they will feel gaslighted and not listened to as part of their maternity care. Do you want to move on to the next slide, please, Charlotte? So the hypothesis, so Sam and I were just discussing how best to explain this. We are not neuroscientists, and we don't necessarily understand the grander detail of how virtual reality really works on the brain. We do know that virtual reality has found to reduce adrenaline and cortisol release in parts of the brain that somehow is altering the neurologically signaling pathways and network. And that does mean that when you're using something like virtual reality, you can manipulate and change how the concentration, memory, touch, and the visual sensory works. So what that means in a practical term is that the brain seems to want to focus on one place and one thing at the time, and then it changes the memory of any of other things that's associated with the experience. Please don't try to explain me to get me to explain that in greater detail, because that's about how deep it goes. So when we came across the virtual reality technology, we felt that actually it may be an opportunity for us to improve care for women and try to reduce some of those barriers for their anxieties, more so they don't have to undergo these undesired interventions such as sedation or general anesthetic during their labor and birth, and actually has an opportunity to be present during the birth of their baby without the consequence and the higher risk of needing such extreme interventions afterwards or even during. Next slide, please. So the legwork I'll come to, that's probably my most favorite part. So we decided we were going to design and pilot this virtual reality intervention to try and see if that would affect women's experience, but also reduce the anxiety and the phobia so they could actually receive the care that we recommend. We decided we were going to look for 2 years, do a pilot aim of introducing this intervention over 2 years in a clinical setting, and hope that we could use it as a non-invasive and a non-pharmacological opportunity to try and address women's concerns. One of the methods we were going to use, so we haven't quite got to the end of year 1 yet, so we're still collecting this data, that we were going to do a qualitative research piece, mostly looking at women's experiences doing the VR immersion, but also looking at how their perception of how it could work, how they feel about the experience, and how that compares to any other ways they may in the past have tried to manage these phobia and fear or procedural anxieties. And we were so lucky to get into partnerships with the University of Reading, who has supported us to get some research help and to collect the data. And similarly, we have also been so fortunate to be supported by the local maternity systems here in Bob and also the ICB. So the legwork. So Sam and I had this fantasy that we were just going to be able to, we got £10,000, which was fantastic. And we were going to be able to go to a shop and pull off some equipment off the shelf to support, to just basically run with this and give it a try. We then soon enough realized, as most of you will do, that it's not that simple when you are introducing equipment into NHS setting, because infection control, it can be quite restrictive. So you have to have all the right applications and tests and equipment allowances in place before you can start to use any equipment within maternity, within any NHS setting as such. What was also new to us was the digital aspect of this, and what we didn't realize, there's something called cybersecurity when it comes to virtual reality. So we had to liaise with our trust to apply for certificates to ensure that the women's details and the use of these of the virtual reality would not somewhat be affecting any cybersecurity or put women's personal details at risk. And it took probably about 5 months to just get that legwork done. So it wasn't as quick as we initially thought. So anyone out there who feels they want to give this a try, please do just allow yourself time to get these practical things sorted first. We also wanted to look at brands. So I have personally never done VR myself, and I didn't really know what would be good and what works. So we needed to find brands where they meet all of these aspects. Only 2 brands in the world are actually recognized by infection control settings in NHS systems. So that did minimize suddenly our opportunity just to pick something off the shelf. And also we wanted to have some equipment that was easy to use, minimum need of training, because again, if you have to train staff, you have to train our women to use it, then suddenly that does become quite a significant problem in terms of time, cost, and clinic settings. So it had to be made as simple as possible. Then we designed the clinical SOP. We had to get the materials. The virtual reality materials came all the way from Australia, so also not that straightforward, and meet with the reps to try and work out how to use this equipment. And to our surprise, and I'm sure Sam will agree with this, it was really easy. And actually, we could just demonstrate it to women for about 3 minutes, and they would just run off with it. And then they knew exactly how to use it, unlike us, it took a little bit longer. And finally, of course, we're really grateful to our partners at Reading University. They helped us to get ethics through so we could collect the data, and they have also provided us with some master students who are going to help us to collect our qualitative data and do the interview. So it's great. So strongly recommend you to seek support from your universities to get some help, because it saves a lot of time from clinicians to do that. Next slide, please, Charlotte. So this is the intervention we're now looking at. 2 years, we looked at who would we try this on. So year 1, we mainly focused on women with needle phobia, because the easy group to compare and to provide an intervention for. And then year 2, we're looking at more wider procedural anxieties, which can be anything really, as long as we will have an opportunity to assess whether it's appropriate to use something like virtual reality headsets for the intervention. Because there are some episodes of care where presence is actually quite important, and it's not always in the benefit of a patient, although they may think so, not to be physically present. So our inclusion criteria was brief: willingness to try. That's all we asked for. We asked for women to come in and be willing to give it a go. Not necessarily the intervention or the bleeding as per se, but try the headsets and see where that would take them. There was a couple of exclusion criteria, more around photosensitivity and epilepsy, and of course any issues around skin care or poor skin integrity. Also, we have to make sure that our women and birthing people are in a relatively good place psychologically, so we're not reintroducing or reinforcing a trauma that may already be present. So as consultant midwives, we are leading this pilot, and our program, the program that we brought into has 54 different types of programs. Some are narrated, some are still, some are animated, which is Sam's favorite, and some are motion pictures. So it's anything from scuba diving, catching fish. You can go on a zip wire if you are that type of person, or you can sit in a puppy pad with lots of Labrador puppies and chat to them whilst the intervention is happening. It's a one-to-one consultation with the women. They're being referred by the community midwives or from the anaesthetic team or any doctor or midwife in our maternity assessment units, for example, where we tend to find that women will eventually explain that there's just certain procedures they can't have done. And we then do the program, takes usually about 20 minutes, sometimes a bit longer, and then we offer to do the procedure either with or without the VR, depending on where people feel they are. They may not be able to do the procedure right away. We may want to call them back to another clinic appointment to give that a try. And then with the women, we do a care plan. So we look at how are we going to manage this coming into a labor birth process and what would that look like, and what do we need to put into place. Next slide, please. So of course, due to the nature of the cohort, it's relatively small. We've done this for 7 months because we had to take the 5 months out from all the practical stuff. And so far we have had 15 women coming through into the clinics. 17 referrals were done. One woman chose to decline and one never showed up, and we couldn't reach her anymore. So we took her out of the study. Out of the 15 we have accepted up to now, 14 of the women had severe needle phobia and one woman had health anxieties, which was mostly sort of tied into the old-fashioned white coat syndrome. So every time she just couldn't have her blood pressure taken, or if she had it taken, it was extremely high. So we wanted to give her the opportunity to try and see if the VR could in fact bring down her vital signs. And we found really quite promising already that the 36% of the women who attended the clinic, they had no pregnancy screening prior to the intervention, so no booking bloods or screening offers in the first or second trimester. And 22 women had previously had some exposure prior to the pregnancy where they had to use sedation as part of a healthcare episode. Overall, nearly all the women, 85%, had previous declined, cancelled, DNA'd, or just delayed an appointment because they just couldn't face it because of particularly their needle phobia. 13 out of the 14 women, which is 93%, they completed phlebotomy, and on overall average, 2 sessions were required of 20 minutes each. Excitingly for us were that 6 out of our participants, they needed OGTTs, and they all had successful 2-hour OGTT. And I'm saying that because actually if you have to wait 2 hours for your next blood test, you got 2 hours to get really wound up about what's coming, and women tend to find that really difficult. So we had plenty of opportunities in the 2 hours to try all the programs and see what would work well for them. So it was great to see that these women were able to go through the OGTT. I'm nearly done. So one of the women we had, she was not able to have bloods taken, and after 2 attempts, she left the program. But overall, 7 of the participants have now had their babies. 6 out of them needed IV access and managed to do that. 5 used VR during the cannulation process. 4 also managed to have a spinal block instead of a GA or sedation as part of the care. They all had plans for possible GA if they needed it, but actually managed with the spinal. 3 had elective sections and 1 had an assisted birth. And one of our participants didn't need any support or VR during birth. So next slide, please. So very briefly, some of the observations we've done so far, obviously is still, there are some limitations in the size. So we're looking to increase the pilot now to get some more experiences in. We're still waiting to analyze our qualitative data and waiting to get all the information collected. What we are observing, what we think we see within this is that this is a possible low cost, but actually quite high impact, no harm intervention that can be applied to nearly all clinical settings. What we are really excited to see that women have a huge desire to try and overcome this barrier and really engaged once we get them in the door and they kind of feel they can trust us to take them through this intervention, knowing that at the end of the day the choice is still theirs and this is purely an opportunity. We also see an opportunity to change some clinical practices, such as, for example, in the community setting, how you line people up and wait to go into a phlebotomist to have blood taken. It's not the most conducive area or environment to do that in if you have a needle phobia. And also remember there are other solutions than just being told to take a deep breath in, because this is not in their heads. This is a real problem and it's causing them great distress. So acknowledging the impact that a phobia can have. We've realized that in a theatre, actually using VR there, it had a benefit that it made people stop talking a lot. So the room would go very quiet, which was great for concentration. But also there are certain events around cesarean section, for example, electively, that can be done prior to going into theatre, because there's a lot of people who want to talk to you and check things. And actually all those things can be planned to be done before you do the VR intervention. We really wanted to think about how we can avoid making women dependent on one solution and look at how this can be perhaps used in a more sort of home comfort setting. So using other strategies, such as what we had one woman, Sam, didn't we, who wanted to look at guinea pigs, and she could do that via YouTube. So she found other strategies that actually worked by having experienced the headsets first. The benefit for us is we start to see that women's experiences are positive, they feel in control, and we are increasing their confidence, but also their trust that we are here to try and support them to overcome those barriers. And we can't wait to broaden this into year 2, where we're going to see more of an opportunistic use of the headsets. I think we got 2 pieces of feedback slides, and I'm really just bringing these in. 2 women gave us feedback about their experiences, and please do read them, because I cannot state enough how incredibly brave these women are to come into our clinic and be willing to take part. So this is one, so just give you a minute or so, and then Charlotte, the last slide, please.
Thank you, Heidi. That was fascinating. And we were really interested in hearing how it progresses in future as well.
Absolutely, we will share. There's one last slide, just without details on. So if you want your trust to be a pilot site, could you contact us? This is becoming, I'm doing a PhD on this from, well, next week actually. So if you would like to be a pilot site and we can test this on some of your women, could you please let us know, and we would love to hear from you.
Right.
That's it.
Any questions for Heidi and Samantha? Any hands? No?
Sean, we've got a question in the chat from Jenny saying, did the women who left the programme get offered any alternative intervention?
Well, I guess the alternative is the traditional intervention, which goes back to you just need to sit down and take a breath in or have sedation, because actually there are currently no real alternatives to needle phobia. Jenny, do you want to come off mute and just talk through?
Yeah, I was just wondering, because it's obviously an anxiety-driven condition, if there was any sort of onward referral to talking therapies or maternal mental health services or that because I mean there are alternatives to this, aren't there, that are more therapeutic?
No, absolutely. I think, but that's more long term. And a lot of these women, by the time we've seen them, have already been through a cascade of what we call sort of low intervention mental health services, such as talking therapies. And absolutely, we would also refer them on where that is required. I have to say, by the time we see them, and because pregnancy is so short, we don't have the same long-term opportunity to necessarily provide an intervention that will work within the pregnancy, but they will go back to sort of similar alternatives as they have previously either tried or thought about.
Thank you. Thanks. And any more questions, please feel free to put them in the chat. I'm sure they'll Heidi or Sam will answer questions. Thanks. And on to our next speaker. It's Sally Densham from East Kent Hospitals, talking to us about equitable access to perinatal mental health.
How to follow that presentation, my goodness.
And Louise, sorry, I forgot Louise.
And I'm sure Louise and I may well be in touch about being a pilot site in East Kent. We have a lot of needle phobia amongst our demographic in East Kent, so we'd probably be very interested in talking to you further about that, Heidi. Yes, anyway, hello everyone. My name's Sally Densham. I'm one of the mental health midwives for East Kent Hospital's NHS Trust. I also work 0.6 of my hours as the specialist mental health midwife for our local maternal mental health service, Thrive, which I'll come and talk a bit more about. And somewhere on here is my lovely colleague Louise. I don't know if she'd like to introduce herself to you all.
Hello, I'm Louise. So I am the newest member of the team at East Kent. So I took over from Maisie, who kind of launched this project alongside Sally. So I can take absolutely no credit for anything that is in this presentation. I'm just here to kind of champion the work that they've done.
Oh, bless you. And Maisie kindly signed us up for this, did the project, signed us up for this, and then went on maternity leave. So, bless her. I'll let her off. She's very busy being a mum to a new baby now. So I've got my own notes here, but I will just refer to as well, because I haven't had a lot of chance to practice. So I'm going to begin just talking a little about the scope of our role as mental health midwives within ECHUF, just so you've got a bit of an understanding really of what we do. Talk about our recent improvement project, and then I'll come on to talk about what we've done, what the improvements we've made, the challenges we've encountered and how we've overcome them, and then if there's time I'll take any questions at the end, which I'm more than happy to take. So our role as mental health midwives is multifaceted, as you'd expect. We have quite a large multi-site hospital. We're a large multi-site hospital trust in East Kent. We've got 3 main sites. We've got the William Harvey at Ashford, QEQM at Margate, and we've got the Kent and Canterbury Hospital in Canterbury. And we have approximately 6,500 births a year. Over the last couple of years, around 50% of all the women and birthing people that have booked with us have had either a history of mental health concerns or a current mental health concern. So we're talking every year, several thousand women booking with mental health, perinatal mental health problems. So as you can imagine, we don't caseload. That's not our role. We don't offer a caseloading service. Instead, we focus on coordinating and delivering education and training to build confidence, knowledge and skills of our colleagues, our midwives and our obstetricians, and enable them to better support women's mental health in pregnancy and postnatally. We provide midwives and the wider MDT with an easily accessible source of information and advice, helping them to make appropriate and robust mental health care plans that support the safety of the mother, parent and unborn or infant. We recognise in everything we do the importance of that parent-infant dyad. So the plans we make, we're always bearing in mind what's best for the mum, but also what's best for the unborn or the infant as well. We ensure that local professionals know what perinatal mental health is, and it's everybody's business. And, you know, we help to support their contributions to effective pathways of care. We work as champions and advocate for families affected by perinatal mental illness to improve services in the local area and help in individual cases to ensure the family receives the support they need. We highlight gaps in local provision and help commissioners and managers understand what changes are needed and why. And we act as a point of contact for other services external to ECHUFT, including social services, health visitors, GPs, other mental health services. Excuse me. Where did I get to? Sorry, I've lost my nose. So at the sort of heart of everything we do, we're looking always at quality assurance, making sure that we're offering the best service we can that sits in line with national guidance. And our role, I suppose, doesn't replace, but it supports the role of all our midwives and our wider MDT in caring for the mental health of women and families we work with. So it's just a nice little slide there that just shows the different facets of our role, really. It's quite, yeah, it's multifaceted, it's interesting, and no 2 days are the same, which is why I probably love it. And it appeals to me. Where are we on? Next slide, please. Yeah, so here's our improvement project. This is just a bit of a very brief overview. So last year, we started off setting an ambition in line with the launch of the Maternity and Neonatal Improvement Programme to create equitable access to perinatal mental health services by March 2025. And I'm pleased to say we achieved it in the whole. Services that fell under the wider umbrella of wellbeing and patient experience, including our birth afterthought service, patient experience midwives, our in-house women health counsellors, and ourselves, we all came together to scope and design an improved service. So we started by examining the scope of each of our services, their purposes, differences, eligibility criteria, delivery aims, to see what was working, what wasn't so successful, and where we were at risk of duplication, just to make sure that we were all understood each other's roles, you know, really well. And then we conducted a gap analysis that allowed us to benchmark the services we have against those offered nationwide. Through doing this gap analysis, we were able to identify some key areas where we could grow and innovate. And then we successfully increased our workforce provision for specialist midwifery hours. And that was the key, really, to be able to make sure that we could do the project and it was successful, because when we first started, Maisie and I were sharing one whole time equivalent role, and it wasn't enough to us to be able to get this off the ground to have, so we needed more provision, which we were lucky to get. So this then became the sort of bedrock, really, for building the project on. So we're now both full-time as mental health midwives, and as I've said previously, I work 0.6 hours of my time for Thrive, which is our local maternal mental health service, which supports women and birthing people with PTSD level symptoms of birth trauma or traumatic loss of pregnancy. One of the highlights, particularly for me, of the MNIP initiative was the introduction of the joint antenatal mental wellbeing clinic. So this is a clinic that we sit in with our lead obstetricians. Excuse me. We have 2 lead obstetricians. We have the lovely Jenny Essex at Ashford and Louise Lee at Margate, and I sit in with Louise in her clinic. And Louise, it's very confusing, there's lots of Louises. Louise Nella sits in with Jenny Essex most weeks, and this combined approach means that we've got the expertise of the obstetricians, but also our expertise in care planning, understanding the pathways, and being able to speak to women about their mental health, women and birthing people about their mental health, means that we've got this nice unified approach to addressing mental health needs of the people we see. And we offer immediate referrals, so you know, I can be doing the referrals alongside in the clinic, or Louise can. So there's no delay in getting those referrals done if they're needed. We can signpost for support immediately. We can build rapport with women so that if they feel comfortable contacting us outside of the clinic setting if they need to. We do wellbeing birth plans with them. We can take them on tours. We can do that in the clinics, or we can arrange to see them outside. So it works really well. But the main thing is we're ensuring that we're making sure they've got good, robust plans of care for their mental health alongside the plans that have been put forward for their pregnancy. So and the feedback we're getting is good from those that are attending the clinic. We've also streamlined and digitalised our referral process, which has been a big success. We were getting a lot of referrals coming via email and different ways. So now we've created a digital referral form, which means when it's filled in, it creates a patient tracking list, and we're able to keep much better track of the referrals we've received, which is good for audit purposes and just be able to look back on. So referrals for our service can be found in a single location on the Trust website, which is good. This we have better oversight between the services as well. So for instance, our birth afterthought service, women can self-refer through a digital link on the website as well. So we can look at what is coming into our birth afterthoughts colleagues as well. And sometimes we refer between ourselves, so it's really handy that we share the same patient tracking list to see what's coming in and have oversight. It simplifies processes for our colleagues, which is always good. We know that our colleagues are really busy, and if anything we can do to simplify referral, we will do. We're there to support our colleagues as well. And it does impact. At the moment, we don't take self-referrals for us because we would be inundated. I don't think we'd be able to manage it with just the two of us, but our colleagues, our birth afterthoughts colleagues, and our women's health counsellors do take self-referrals. So we wanted to make it easy for women and birthing people to refer themselves if they needed to, reducing health inequalities and ensuring patients are accessing the right care at the right time as well. Just a bit more. We now run as part of the improvement, we run a simulation-based training via our annual mandatory training programme prompt sessions. This equips our colleagues with skills to respond effectively in mental health emergencies such as postpartum psychosis and rapid tranquilization. So being included on prompt has been really, really helpful, and it's helped us to talk about the pro forma that we've created as well as part of the improvement programme. So we've created a crisis pro forma, and the crisis pro forma sits in a folder with the rapid tranquilization policy, with our local modified risk tool, and everything everyone needs in a mental health crisis, so that colleagues can just grab the folder. It's all in there. It talks them through, the pro forma talks them through step by step what they need to do and what they need to consider. So we've been able to introduce the pro forma in the prompt sessions, which is lovely, and give our colleagues that reassurance that they've got this tool to use should they be caring for someone in a mental health crisis, because it's scary, and we recognise that if you're faced with that, it's a very frightening thing to be dealing with. We've also appointed mental health link midwives across our 2 acute sites. So we've got Donna at Ashford, and we've got Claire at QEQM. And this helps us if we want to disseminate information. We can do it through our link midwives who are on site. So that helps as well. And one of our ambitions, which I'll come on to, is to create some link roles in the community teams as well in the future to further promote the information sharing and support for our colleagues. Okay. Next slide, please. Just check I'm on the right slide. Sorry, bear with me, I'm not very good at driving these. So as you can imagine, we've had some challenges with implementing the improvement programme. One of our biggest challenges is our large geographical area and being a multi-trust site. We do cover a very wide area in East Kent. So we also have community teams. So we have the main hospital bases at Canterbury, Ashford and Margate, but we also have community teams in Folkestone, Dover, Herne Bay, Whitstable. So we're a large area all the way down to sort of Dymchurch type area as well. It means our services can be stretched, as in mental health midwives. If we are wanting to go and visit people, we have to factor in time for travel. We're a small workforce still, as 2 whole-time equivalent mental health midwives and 2 lead obstetricians. We're a small workforce, a small team for the area. Our clinics are very busy, they're oversubscribed, and we could do with, having dedicated registrars in the clinic at QEQM. We do have one at Ashford now, and that's made a big difference, but we could do with that at QEQM, and that's something I'm going to work on this year, to make sure that's equitable and we have that at each site. Okay. Sometimes it can feel that, we're doing a lot on the phone, which isn't my preferred way of working, but in order to reach everybody we need to reach and, keep up with the demand, we do a lot of work on the phone, or by video call, which is fine, but it's not quite as good as being in person. But we can't fit everybody into the clinics, straight away. It can take time for projects, for services, to align across the different hospital sites. So we need to make sure the information gets disseminated equally and effectively, and everybody is doing the same thing. So that's why we needed to make sure that we used tools to improve our sort of communications. We do send a lot of communications out via our maternity Facebook page, our staff, I should say, maternity Facebook page, to make sure that we're using different ways of getting the information out there if we need to. We use message of the week, and lots of other ways of disseminating information. Definitely since COVID, we've seen an increase in the number of patients booking with, mental health problems such as anxiety, trauma. And as I said before, this is sitting around 50% of all our bookings at the moment. So we do find that we're busy the whole time. Really, we never have a quiet period, which is fine, but it can make it difficult for innovation. We have to deliberately carve out time in our diaries to work on new projects, because we could spend every single day speaking to women and birthing people, all day. So we have to be deliberate about that and make sure that we are carving out time to work on things. I would say, although we're included on the prompt training and have been very grateful to be included this year, we don't have a dedicated slot for general perinatal mental health on the current training programme. So this does create, as I said, a challenge for us in keeping colleagues up to date with their knowledge. So we are relying on putting out regular communications. We've tried things like lunch and learn and they're just not well attended, because people can't get time away from work to be able to attend them. So we've tried various different solutions to it, which have fallen by the wayside because they just were not well attended, unfortunately. So as I said, much of our time as well is dedicated to offering support to women and birthing people whose particular mental health concerns mean they're at risk of falling through the gaps in services. In particular, we tend to offer dedicated support to those with long-term mental health concerns, such as complex PTSD, or those who have any sort of neurodivergence at all. To my knowledge, there aren't any dedicated services to meet the needs of women and birthing people in the perinatal period that have these diagnoses. So I'm particularly passionate about being able to offer these women and birthing people our support, so that we can create personalised care plans for those who struggle with trauma, or who struggle with sensory issues because of their ASD. However, we would really benefit from having a more dedicated specialist midwife, for this group of women and birthing people. It's definitely something I would love to see in the future, is a dedicated midwife for neurodivergence, for example. That would be amazing. Next slide, please. How are we doing for time? Am I all right? Completely lost track of time.
We're just at the end.
Just at the end. Okay, I'll speed up a bit. So we've tried to come up with creative solutions to overcoming our challenges. And one of these things we've done is to implement HUGS, which was already running in Medway and MTW. HUGS stands for Helping You Grow Stronger. And it is it's an antenatal psychoeducation group, really. I think that's what we would call it. So we talk about tips and techniques to help women in birthing people support their own mental health. We talk about different issues that might be concerning or worrying people and looking at solutions. We talk about all sorts of things. I don't know if you can see it on the poster there, if it's big enough, but that says what it covers. So we talk about parent infant mental health a bit. We talk about identifying support, building your tribe, difficult conversations, postnatal mental health concerns. So just it's quite a nice overview, and we run it every week on a rolling basis on a Friday morning via Teams. There's no people have to people that want to come have to self-refer to us, and then we send out a PHQ and GAD9 questionnaire for them to complete and send back to us, so that we can just check for risk before we accept them onto the group and make sure that they're not sitting at the severe end of mental health concerns, because this is designed for people with sort of mild to moderate mental health problems, not moderate to severe. If we do identify somebody having more severe concerns, we would then get in touch with them directly and offer some individual support and care planning. We've also created a patient information leaflet, as you can see there, which provides clear details about the services and support available. And again, it underscores our commitment to transparency, accessibility, making it easier for families to navigate the systems that we offer and the support systems we offer. As I said, we've streamlined digital referrals. So yeah, we've done a lot to try and overcome the challenges, and we're constantly striving to improve our services. That never stops. We don't feel like we can sit back and we're there, far from it. So our next ambition for Louise and I, and a little project for Louise to do while she's with me, and we can do together, is to provide our lovely triage colleagues with a pro forma or guide to use if women or birthing people call in a mental health crisis. We've noticed more and more recently more calls coming into our maternity triages from women and birthing people in mental health crisis. And it's challenging to deal with this on the phone. We know, because we do it as our role. It's challenging to deal with it for our colleagues, and it's something that causes them a great deal of anguish, as you can imagine. So we want to better provide a guide, a pro forma, something similar to what we've already provided for our colleagues working on the wards, to be able to offer some guidance and some reassurance. So we'll also hopefully create an alert system that will notify us when one of our crisis pro forma has been used, so that we can follow up. And we'd also like to further digitalise our appointments and internal systems, and hopefully recruiting some community linked mental health midwives. So we've got lots to be getting on with in 2026. We can't sit and rest on our laurels, far from it. So that's about it. Any questions, please? Next slide, sorry.
Thanks, Sally. That was fantastic. Thanks.
Right.
Any questions? Margaret.
Hi, thank you for that.
That's okay.
I'm Margaret. I'm from Hampshire and Isle of Wight, LMNS.
Hi,
I've got a
Margaret.
question and a bit of a statement, if that's okay. And
Yeah.
apologies if I missed you saying this. So obviously you talked about 50% of bookings with the mental health diagnosis. I was just curious of all the referrals that you had. Did it align to your locality demography?
Yes. So in terms of deprivation and that sort of thing, is that what you mean? Is it
Deprivation and ethnicity, I was thinking.
Yeah. So we've looked ethnicity, majority white British are the referrals we receive, and yes, there is definitely a link to the deprivation index. Of more deprivation is associated, as you would expect, with increased mental health concerns. So we do collect that data, and we look at that every month as well, and it hasn't changed. Despite what we're doing, we seem to be, and something I would like to do as well, and is an ambition, is reaching some of our harder to reach groups. But we have a consultant midwife who works with us, who is working on that. So we're trying not to duplicate work as well, because we have a consultant midwife, and that is very much her remit, to access, and we work together. So she will access the groups. We will support with that if we need to, offer care planning advice and support. So it's lots of liaising, but it's definitely something we're aware of and conscious about, is that we'd like to be able to reach the harder to reach groups. Definitely.
Yeah, and I
I
think
don't know if I answered that, sorry.
Yes, I was just curious what you did for those underrepresented communities, because the traditional way of NHS and working NHS within communities doesn't really, in Hampshire and Isle of Wight, I can talk about, doesn't really work for those communities. And we have to work differently to reduce that stigma. So I was just curious, had you done that? And then I think
we work very flexibly. I'm happy to visit anybody at home. My background is a community midwife. I like to be able to offer flexibility in my approach. I definitely do that in my Thrive role. So we will work. I will work however somebody wants to work with me, whether that's face to face. But that comes at a cost, and that cost is our energy. We don't have great resources. Even being 2 full-time equivalent midwives for the geographical area we're expected to cover, it isn't enough. And we are being expected to support a lot more women and birthing people with neurodivergence than we've ever been expected to support before. And there's an argument that isn't necessarily and strictly a mental health midwife's role, that there should be a dedicated specialist midwife to do that, but we do not have that in our trust, so that gets given to us as well. And I have a particular interest in that, because my son is autistic, so I do have an interest in supporting this particular group, because it's very personal to me. But that's the reason, and my motivation for doing it is my personal interest and my own experiences of raising a child with autism. So it's not ideal, is what I'm saying, and we need more workforce. We definitely need a larger team, for
Thanks,
sure.
everybody. Right, I'm afraid we're going to have to move on as we're running out of time, but thank you. Great conversation, and if you want to carry on the chat, please feel free.
Thank you. Thanks everyone. Thanks for listening.
Thanks. Our next presentation is from Liz Callan and Jenny Walsh, talking to us about the South East Perinatal Provider Collaborative. Over to you, Liz and Jenny.
Hi everyone. I'll try and speed up a bit, because I know that we're going a little bit over, so I might sort of rush through some of these slides if they're a bit wordy, but you'll get the slide pack anyway, so you can have a look at them at your leisure. First thing I'd like to say is it's really lovely to be invited, and there's lots of people on the call that I've worked with, and so has Liz in previous roles, so really lovely to sort of re-engage.
We've lost your sound, Jenny.
Oh.
I'm very quiet.
We can hear you, it's just that, oh, no, you're on mute now. It's just quiet.
Yeah, how's that? Is that any different?
Much better.
That's better.
Oh, okay. One of those switch it off and switch it on again Teams things. So now those of you that worked with us before would probably remember us from our role as the leads of the Southeast Perinatal Mental Health Clinical Network, and we've now popped up in this different role for the Southeast Perinatal Provider Collaborative. And I guess that's a term that won't be familiar to most of you, because I think I'm right in saying this is a mental health initiative, and physical health don't use this similar model. But what it basically means is that it pulls 2 or more provider trusts together, so hence the provider bit. And literally it does what it says on the tin. It's about working collaboratively together. So how that works in the Southeast is that across the whole patch, we've got 2 mother and baby units. One is in Kent at Dartford, the Rosewood unit, and the other one is in Hampshire at Winchester, Clover mother and baby unit. And that each of the units is 8 beds. So I guess you might be thinking, well, what's all the fuss about? That's only 16 beds for the whole region. But what we would say is that's exactly what the fuss is about, because it's a very tiny, tiny resource. And what we are tasked to do is to make sure that everybody who needs a bed accesses a bed. And that covers all the stuff that Margaret was just talking about who's missing, where are these women? Are we seeing more white women? Yes, I think we are. Do we have hidden populations? Yes, I think we do. And I also think within our geography, there are some ICBs that are less represented on our MBUs than others. So to do the work properly, we really have to understand not just who we're seeing, because once you get to a mother and baby unit, you tend to have a much better recovery, and all the outcome measures are fantastic. Whichever way you look at it, people do very, very well on mother and baby units. But we're as interested in the ones that aren't getting there, that should be, the ones that are missing out. So that, in a nutshell, is kind of what we're trying to do with the work of the Provider Collaborative. And the difference between normal commissioning and provider collaboratives is that people like me are really heavily involved. So there's a heavy clinical representation and voice, but also lived experience. So as we all know, you can't possess the citadel from the outside. And if we're really going to change things for these people, and I don't like hard to reach communities, I think it's hard to access services. Bang on about this quite a lot, but it's very, very much about finding the ones that are missing, meeting those communities at the very best place for them to be met, finding out what the blocks are and working with them to try and overcome some of that, and so that all the women that need a service can get one. Okay, next slide, please. And this quote kind of sums it up. I should have gone to this one first, because this is an expert by experience from the National Provider Collaborative Implementation Group, and they have summed it up in a lovely way, and I will read it out because I think it's fab. A successful provider collaborative is, for me, all the right people around the table working as one to improve not just individual services, but the way women access them and what happens after they do. I think that's so important, because if it doesn't matter if your service is excellent, if only certain people can access it and they drop off a cliff when they leave. So it's the whole pathway. A good collaborative will involve women like me and others in everything they do and not be held back by the way it's always been. So trying to work more innovatively and work differently and make sure that patient voice is really there. Next slide, please. And I think this sums it up really nicely. If you want to check the shoe fits, don't ask the manufacturer or the shoe shop, ask the person. But absolutely getting that voice of lived experience in there right from the start. Nothing about me without me. Asking those, what would make a difference to you?
You're fading again, Jenny.
Oh.
I think just stick closer to your microphone, Jenny, if you can.
Right. Next slide, please. I might be.
You're handing over to
Liz
me
now. Yeah. So hopefully it'll pick up in the meantime.
No problem. So just a little bit of background in terms of the provider collaboratives. So as I've seen in the chat, some people's experience, so Margaret's experience has mainly been around CYP mental health. Perinatal mental health was phase 2 of the national development of the provider collaboratives. So before perinatal mental health, kind of specialist CAMs, forensic services, etc., had gone forward in phase 1 of the provider collaboratives. And so the national geography is broken up into the kind of the provider collaboratives for perinatal services, but the beds remain a national bed stock. And in terms of the development within the Southeast, so back in March 2024, there was a big engagement event to bring together the stakeholders from across maternity, perinatal mental health, commissioning, where else, health visiting, etc., to really look at what we were going to try and do for the provider collaborative within the South East. And then just in terms of kind of some of the logistics of how it works. So there is a lead provider for the provider collaborative, and that's Kent and Medway Mental Health NHS Trust. It was formerly Kent and Medway NHS Social Care and Partnership Trust, but we became Kent and Medway Mental Health Trust back in October last year. So they are the lead provider for the South East Perinatal Provider Collaborative. They take the pot of money in order for us to commission from, etc. They host Jenny and myself and the posts within the Provider Collaborative. And the main role is to take the responsibility and the contract to deliver the services on behalf of the Provider Collaborative. So the Provider Collaborative contracts both Rosewood MBU and also Clover MBU to deliver the services. And then we have a partnership agreement between all the collaborative members in order to how we will work to deliver our objectives, etc. And so although the commissioning responsibility at this stage is purely around the mother and baby units, in order to make this work, in order to kind of make our pathways better, etc., we have to take a whole pathway approach, thinking about that interface, ensuring that our specialist perinatal mental health community teams are involved, but also other key stakeholders like yourselves in maternity, etc., in order to work together, you know, to create our vision and our work streams. But in terms of the specific commissioning responsibility at this stage remains the mother and baby units, and the ICBs still commission the specialist community teams at the moment. Can I have the next slide, please? So within the South East, our provider collaborative went live back on the 1st of October 2024. So we've been live just over a year now. And at that point, the only person that was actually in post was Jenny. I had been offered the post and went to the go live, but wasn't in post at that point. And of course, as anybody who knows me from previous roles will know, I do anything for a piece of cake. So we made sure that we had lots of cake at our launch. And we had a live feed between our two mother and baby units, so in Dartford and also within Clover at Winchester for the launch. Can I have the next slide, please? So as Jenny said, in terms of our geography, you're well aware of the South East geography. Obviously, we've got the two MBUs, as Jenny said, 8 beds on either side. And then obviously we've got the ICBs, 6, but obviously that's changing in terms of the footprint at the moment. So we need to update that going forward. Can I have the next slide, please? And then just a little bit in terms of our governance structure. So historically, obviously, these services were directly commissioned by NHS England, and hence that has passed over to us as a provider collaborative. But we still currently are assured by NHS England and the ICBs. Now, on the 1st of April 2025, that role theoretically moved from NHS England to the ICBs. But as obviously this is in development, what was agreed certainly for the South East was that NHS England and the ICBs would take on that role collectively together for the up until 2027. So we have regular assurance in terms of, you know, whether we're hitting our objectives and ensuring that our clinical safety and quality of care and that, etc. So we meet with NHS England and the ICBs in order to discuss that. And then obviously we oversee the quality and safety of the two units, as well as commissioning them and ensuring, you know, their development, etc. Next slide, please. We are a tiny little team. So it is Jenny and myself. We're both part-time in these roles. We also have some part-time admin support from Phoebe, and we currently have 2 vacant posts within the team. So tomorrow we are interviewing for our engagement and improvement lead, which we hope we will successfully recruit to. And that's obviously to make sure that, obviously, as Jenny referred to earlier, that service user engagement and that is absolutely embedded in everything we do in all our work streams. So they will be a key member of the team in terms of ensuring that happens. And then we also have a vacant post, which is a case manager post. And the role of the case manager is very much to ensure that we have smooth admissions, but also repatriation for women that are maybe So South East women that may be placed out of area to other beds nationally, but likewise in the reverse as well. So that is us as a small little team. Next slide, please. So I'm going to hand over to Jenny, who's going to talk through a bit about the work streams and the interfaces to where they are in terms of some of your own work streams.
Okay, so I guess with the sort of overview, a lot of people on the call who are clinical might have sort of glazed over a bit because you're not always as interested in that sort of more strategic stuff and the way systems are set up. But I think this is the bit that might float your boat if you're clinical, because these are the areas that we have agreed through our engagement events and working with stakeholders across the South East that should be our priorities. You won't be at all surprised to see that the first one is health inequalities. And as I've already alluded to, looking at making sure the MBU is representative of the population. And also, our previous speaker will be pleased to hear we're trying to improve our structures and training for supporting neurodivergent women. And that is a really emerging.
Sorry, you've gone quiet again, Jenny.
Oh, no. If I do that, is that better?
Yes, thank you.
Is that a bit better? I have no idea, but just tell me and I'll keep switching on and off. Yeah, so really important to make sure that we're doing the best by these women, because I think it's been a bit of a hidden population, and we're just sort of at the beginning of realizing how much we've been misdiagnosing and not treating appropriately. So really exciting times to get that right. Access and egress is about, as Liz has alluded to, standardizing how you get into and how you leave a mother and baby unit. And I think as midwives, this one is again really, really important to you, because you are often the people that see these women first. You might be seeing them in crisis first. If you think they need to get into hospital, you need to know exactly how to do that. And if you get any blockers, you need to know where to go to get doors opened or whatever it might be. So that's really important. And workforce training and education, because you'll all be aware that perinatal mental health had its moment in the sun in terms of commissioning, where new services were being set up.
I'm quiet again, Jenny.
Thanks for the heads up. Yeah, when new services were commissioned for perinatal mental health, there was a lot of lovely training money slotting around, and that's all disappeared now. So working out how we can use the South East to have some economies of scale with training, and look at where there's some really good people working that are training that we can. And then we've also got an infrastructure work, which is about kind of sorting ourselves out and getting our governance in place. Next slide, please. These are the work streams in a bit more detail, and I won't labour these so that you can have them at the end and have a look. But as Liz said, that engagement and improvement lead, I think, is going to be a really good post, because we did have lovely Tracy Robinson working for us, who had both her strategic head on, but also her lived experience head. And that was amazing. But when she left to pursue her own career, we knew we wouldn't get another Tracy. So we've gone for a post where, rather than having one person with lived experience speaking for all lived experience in the South East, we've got this engagement post who will be going out to our really marginalised groups to try and help break down barriers and get women more comfortable with talking about mental health, and get those women representing on all of our groups. So that's the plan.
2 minutes, Jenny, if that's okay.
Okay, next slide, please.
Can we just go back one slide? Can I just put a little thing in to promote? So we call it the clinical network meeting just because people know what that means, if that makes sense, although we're not a clinical network. But those are some of the opportunities that you may want to come and engage with us in terms of their good information sharing meetings. Our last slide will have our generic email, so you can contact us if you want to know about that. And also we do webinars and that, so just to let you know about that. But next slide, please.
Some of you will remember the Perinatal Pathways tool that we developed when we were the clinical network. And we're doing a piece of work with Sarah Clark from Hampshire Isle of Wight, who's on the call, I believe. Hi, Sarah. To look at whether we can tweak the tool to cover the ask of the maternity care bundle from the maternal mental health perspective. So just tweaking that pathways tool so that we include Hooley and the Edinburgh, I think, is already in there. So we're really hoping that that will help all the midwives. And I think once we've tweaked the tool, Sarah is going to take it back to SHIP to be a pilot site and to get some feedback on that. So look out for that one coming. And it is great to see maternal mental health care. Yes, you're right, Margaret, recognised. Absolutely lovely. Okay, next slide. Back to Liz.
So just a little bit of a plug. So we were hoping that by today we'd have the link to share in order to join remotely. But this is a piece of work that's been done by the London School of Economics. There's also the World Health Organization who are involved in another element of it. And Alan Gregoire, who many of you will know, who used to work in the Southeast, has worked with Jenny and I over the years as well, a great ambassador for perinatal mental health. He is obviously the kind of the pioneer behind this. So this is around kind of maternal psychological well-being, new developments, and embedding talking therapies within maternity, similar to some of the work that's already been done within neonates and also maternal medicine. So there is an event that's taking place at the end of January to find out a bit more of that. So we just wanted to plug that because I think there could be some really exciting stuff going on with that and opportunities to be sort of pioneers for taking this forward. So as soon as we have the link, we will share that with Charlotte and Sean to send out. And could I just have the last slide? Just to give you our email address. So if you want to hear more about what we're doing, if you want to get invited to any of our meetings, forums, or whatever, or just say hi, because it's been a while since we've seen some of you, do get in touch. Thank you very much.
Thanks ever so much. Sorry about the rush there.
That's
so much
okay.
Good things to talk about. Okay, and we'll move on now to our last presentation, but by no means the least, the Southeast Neonatal ODN psychologists, Siobhan and Jacinta, over to you.
Hello, good afternoon, and thank you for having us. I'm Jacinta Caldwell, and I'm here, as I said, with Siobhan, my colleague. We're both consultant clinical psychologists and psychology leads across the Southeast Neonatal Networks, which collectively oversees 27 neonatal units. Today we want to talk to you about the developing role of psychology within neonatal care, a field that has grown significantly over the last few years. And I think this growth has come from a real deep recognition that neonatal care isn't just about medical survival, but about that kind of emotional well-being, relationships, and the longer term kind of outcomes for babies, families, and staff. So next slide. So I know time is really short, so we're going to whiz through some of this. So just a snapshot of kind of three key areas. What we do, so the role of psychological professionals within neonatal services, both at a unit level but also regional. Secondly, where we've kind of got to, so the progress we've made nationally and regionally, and some of the challenges that we faced along the way. And finally, just thinking about our what's next, so our plans for further development and embedding psychological thinking across neonatal care. So next slide. So this slide really just sets the context of our work. So the role of neonatal psychology professionals really involves thinking about the baby, parents, families, and staff within a nested system, kind of really recognising that each layer influences and supports the others. And I think this interconnectedness makes it vital that we work across all levels and all layers. But there is also overlap in thinking and the work we do around adults and perinatal mental health, infant mental health, and paediatric health psychology, particularly in supporting families through illness and hospitalisation. And for this reason, we work closely with other services to ensure the holistic needs of babies and families are met, both during an admission, but also after discharge and once home. Next slide. So the themes of infant and family experiences are a whole talk in themselves, and these are some of the sessions that we have been delivering locally across the Southeast. But this slide really just provides a bit of a summary of the important issues and challenges for babies, parents and staff within this nested system. So for babies, they're born too soon or too sick. They're exposed to sensory overload, to pain and to repeated interventions. There's often frequent separations, multiple caregivers, with often very little opportunity for rest and predictability for these little ones. You know, we know that babies are dependent on parents who they themselves might be frightened and overwhelmed. We know that parents often face trauma, anxiety and low mood alongside an interrupted transition to kind of parenthood. And I think it's not something that's unknown that perinatal mental health difficulties are much higher in this population of parents compared to our healthy term babies. And many parents really describe feeling like visitors than parents, especially early on in their journey. If we think about their experiences of often witnessing very invasive procedures on their babies, those kind of constant fluctuations, those ups and downs, that roller coaster that parents describe, and sometimes loss, and that might be loss of firsts, loss of the last part of their pregnancy, and they're doing all of this while they're trying to kind of make complex decisions under really stressful situations. And life outside obviously continues, so they're trying to do that in amongst kind of managing maybe childcare responsibilities at home for siblings, work, finances, travelling back and forth to the unit, and that often leaves quite little space to process what's happening. And then if we think about the staff team, for staff there is often that kind of cumulative emotional exposure. We know that vicarious trauma, burnout, moral distress are really common in this population of staff. They often will see babies kind of die, and particularly in the context of you know, maternity and neonates now, there's often a fear of litigation. And again, very limited opportunities to process the emotional impact of the work while continuing to care for others. And when we step back and we look at this together, I think what becomes really clear is that we have multiple nervous systems under strain, all kind of interacting in the same space, all needing their own layer, all layers of that needing their own support. So next slide. Sorry, I'm whistling through this, but I know we're tight on time, so please bear with me. In terms of providing psychological support to families, that can be at many levels. So for babies, that might involve working with the infant to name and voice their experiences, to carers and to the staff, to support with the development of parent-infant relationships. Sometimes that looks like naming babies' cues, encouraging touch and parental involvement, but also to address things that might be getting in the way of parents connecting with their baby. And we do that often alongside working closely with our AHP colleagues. For parents and family, it often involves kind of working with trauma that is often very live, trying to mitigate some of those current stresses that they're experiencing, and thinking about how we support their adjustment to their baby's admission, the impact of any kind of potential diagnosis that might be shared, and thinking about those multiple fluctuations that can come with an admission. And there's often then work to be done in supporting them around decision making at times when when there are complex decisions to be made about what happens to their baby. And alongside that, that can be work to support the kind of couple who might also differ in their responses to kind of what's happening. And if we think about the staff team, then it often goes beyond what we kind of consider to be trust-based staff support offer, thinking about reflective practice, debriefs, case consultation. And this can be to help staff think about and manage complex situations and families that present with challenging emotions, to think about how we support them with the staff with complex decisions, particularly when there might be a difference of opinion or maybe when a baby moves towards palliative care. Also, where possible, we try to work at the level of the system as a whole, kind of thinking about how we incorporate psychological thinking into all aspects of neonatal care to both reduce and respond to the experience of trauma for all. So I'm going to pass you on to Siobhan now, who will share more about how this work has evolved over the last few years within this area. Next slide.
Thank you. So just going to touch very briefly on workforce development, how we've been supporting clinical practice, education and training, and clinical governance. So if we just move on to the next slide, I can talk you through some of the documents that we produced with colleagues in roles similar to ourselves, working in different parts of the country. And certainly there was a real need when we first came into post, and Liz and Jenny will be very well aware of the fact that there weren't any staffing guidance or models of practice. And that was something that we did work with our colleagues and thought about at the inpatient level. And we've recently published something, a document which outlines staffing standards and model practice and thinking about care pathways for neonatal families after discharge. And this has been really helpful, both in terms of thinking about what our staffing guidance ought to be on the unit, but also thinking about what the gaps currently look like. And this has also been really helpful thinking about not only developing a gap analysis, but when we did receive funding for psychological support on the unit from the Ockenden funds, continuing to monitor where different units were and looking about what money or what funds we would need to have to actually improve support going forward. So if we can just go to the next slide. So this is what the current situation looks like. We've made huge strides in how things look, but and real progress, but also there's still quite significant gaps. So our inpatient staffing currently sits at about 30% in comparison to recommended levels. And in outreach, unfortunately, and that's post-discharge, there are no services, there is no support. And it's also worth highlighting, unfortunately, that Kent, Surrey and Sussex are the lowest resource support for or offered support for emotional support in the country. So I think if we can move to the next slide. Another key thing we've been involved with our national colleagues is thinking about education and training, thinking more broadly for staff and how to build psychologically informed neonatal care. And some of you will know that there's now an online e-learning program to kind of build that knowledge and skill, and anybody with an NHS email can access that at no cost. So anybody who's on the call is very welcome to do so. We've also been involved in supporting standards for psychologically informed care in terms of nursing training, and we're actually involved in the delivery of that regionally as well. And we had our first specialist neonatal psychology conference to support the practice and clinical skills of our psychologists coming into role in the different parts of the country. So if we can go to the next slide, we can just look a little bit more about what's happening regionally. So we've been involved in looking at a training needs analysis, and also involved in quite targeted and focused training for particular units, but also thinking about our local nurses as well and developing their knowledge and skill. And also thinking about compassionate leadership for our matrons and senior clinicians, as well as managers. And that's been more developed in TVW. We were also involved in the clinical development and knowledge and skill of our psychological professionals, many of whom were new to neonates when we did receive funding, and we've developed quite a comprehensive education package. So if funding does become available, then we have something that's quick and ready and available and can guide people in their learning and development. Next slide, please. I just want to touch very briefly, thinking about what other resources have been developed. So other colleagues in different parts of the country, we've collaborated with them and developed some resources and Padlets. Some of them thinking about how to have complicated conversations or supporting families in distress. And this was something that was developed in the wake of the trial. And we're also mindful of the lens that is on neonatal care at the moment. And hopefully this continues to be helpful for our staff. And we've also published a number of papers, again, just really building knowledge and skill around psychological thinking, and to offer that lens to people's practice. And we've also got quite a comprehensive induction package that's there. So when new psychological therapists are coming into post, that there's something consistent, and even though there might be variable coverage across the different regions and different parts of the country, that hopefully new practitioners coming into post will be well supported. I'm just mindful of time, so I just want to skip through the next couple of slides. Again, this is just touching a little bit more of what we've developed regionally. I think it might be useful to just touch on a little bit of the challenges that we've encountered. Funding continues to be a challenge. We're also only 2 days in our post. We'd like to offer more and continue to develop more, but that continues to be a challenge. But also for people to have time released to start thinking more in this way, and for us to really build that knowledge and skill across the network. Jacinta, I'll hand back to you for the final slide, which is thinking about where we hope to go next.
Great, thank you. So just to finish, we really want to just briefly outline what's next in this work. So in terms of workforce development, our focus is really on continuing to support individual units to maintain the psychological provision they already have, should they have it, which we know isn't always easy in the current climate, but also providing practical support with business cases so that units aren't having to make their art on their own in kind of doing that. Around education, we're really keen to keep embedding psychological thinking across the wider neonatal workforce, not just within psychology roles. Siobhan and I are currently talking and working through developing a webinar series for this year. We're also beginning to think about the possibilities of doing some trauma-informed care workshops, again, across the network, so that that's a kind of shared resource. And any ongoing CPD opportunities, all really aimed at building neonatal psychology as that kind of as a recognised and sustainable specialism. For supporting clinical practice, I think a key priority is really going to be strengthening our links with community and maternity services, so psychological work feels more joined up across the whole pathway. I think we've made massive strides in that, and I think it's about kind of continuing to do that. We're also planning away days for our psychological professionals across the Southeast to support connection, kind of reflection and that shared learning. And finally, in terms of kind of clinical governance, we're continuing to kind of collect and analyse outcome and activity data locally and regionally, and hoping that that builds up the evidence base for continued funding and certainly additional funding. I think that's really important, as we said, yeah, to kind of build our workforce. So that's kind of where we've kind of got to. I know it's really brief, it's very quick, we've kind of gone through that, but I think our next slide is just a thank you. And should you have any questions, here's how to contact us. So yeah, if you have any kind of questions, our email address is there, our LinkedIn QR codes to access us on LinkedIn is also there. Very, very welcoming of any kind of contact that you might want to have. But thank you,
Jacinta, Siobhan. That was a really good run through, and I'm sorry about the time running out. Any questions quickly? We have a minute or so for questions, if there are any, either for Liz or Jenny or Siobhan and Jacinta. If not, you know how to get in touch with everybody, and it's been great today listening to use of technology, how people are collaborating and working with women, the importance of the new fields coming through about neurodiversity and psychology within neonatal. So much to talk about, and so much overlap, as it's been mentioned in the comments there from Jenny, that all of this blends together. Going forward, it's good for us all to keep in touch. And as Charlotte's mentioned, there's also the PMA work that's going on, and there's a course starting for the PMAs for midwives, professional nursing advocates as well, for those in the neonatal arena. And if anyone's interested, there's a new course starting, they could put forward their application for that. Thank you everybody so much for their time. I'm sorry we didn't have more time for discussion today, but it's a packed agenda. If anybody would like to see the webinars, it's going to be online. We put it up on the website as much as you can with all the slides. And can I just thank our speakers today for their fantastic presentations. And if anybody would like to feedback on us, there's a link on the last slide, which is for our feedback on today, because we want to make these sessions as useful as possible for you. And thank you so much for coming, everybody, and for listening and hanging in there today. It's been a great day, so much thought and interest. Thank you very much.